Welcome to Off the Cuff, EviCore's podcast. I'm Julius Torelli, Chief of Cardiovascular Services at EviCore. And joining me today is my co-host,
Liz Avila, Vice President of Client Experience with EviCore.
You say off the cuff 3 times.
Off the cuff, off the cuff, off the cuff.
Very good.
I had to concentrate. So today we're talking about the 8 most common inappropriately ordered tests. Should we start off with echocardiograms?
I think that would be a great one to start off with. So an echocardiogram is a fancy term for ultrasound of the heart. It's one of the coolest tests ever. It's probably one of the things that made me go into cardiology because it really shows you the heart, the size of the heart, the structure of the heart, how thick it is, how it's working, how, is it pumping right, all the valves, are they leaking, are they closed off? It's an unbelievable test. And there's no radiation exposure. It's done by ultrasound. And it makes diagnosing certain things so much easier than what we had, let's say, 40 years ago. So ultrasound's been around probably, at least echoes, 30 plus years, maybe 40. And it's really simplified things. However, as with everything, it's easy to do. Most cardiologists have the machine in their office. And so it's kind of replaced the stethoscope in many ways. So they rely on the echo a lot more. So we see inappropriate requests in a lot of different ways. The most common inappropriate request, and this is true in medicine in general, is the routine request, right? The annual, you come back, you had bypass surgery, you're feeling fine, your bypass was 5 years ago, you're working, you're not having any symptoms, and you come back to see your cardiologist, and you're going to get a nuclear stress test, an echocardiogram, maybe a carotid ultrasound, maybe an ultrasound of your abdominal aorta and your lower extremities, all whether you need it or not.
Yeah.
Right? And that's just, routinely done. And a lot of patients think that's good care.
Right.
My doctor, he's so thorough, he really cares about me, because he does a nuclear stress test and an echo and carotid, whatever, every year, just to make sure that everything's okay. And it turns out that there's no value to any of that. We pretty much understand that. The societies understand it, the guidelines. There's no appropriate use criteria that really, fosters the routine use of kind of any testing. I mean, there are some times when it is appropriate if you've got a closed off valve that's severely closed off and you're following it, decide when to do surgery. That's one indication, but not for everyone, which it tends to be done. So if we did nothing else in cardiology but got rid of all the routine unnecessary testing, we would save, across the country, we would save billions of dollars. I mean, it's that much. Cardiology is obviously, coronary disease is common.
Right.
Bypass surgeries and stents and things like that are common. So I think patients have to understand, and physicians as well, that just because you're not getting a test does not mean that you're not getting good care.
Right.
Right. Come back, get seen, make sure what's going on in your life. How's your cholesterol? How's your blood pressure?
Yeah.
How's your sugar doing? Are you smoking or not? How active are you? And things like that. That's the importance of it. Are you having symptoms?
Right.
That changes everything, right? If you're not having symptoms, you're doing well, the tests aren't important. But if something's changed, if all of a sudden you're like, since last year, kind of those symptoms I had before my surgery, seem like I'm getting a little not as bad. That may be a sign that you do need to do the test. And so we really work hard. And then again, it causes some inefficiencies because a lot of physicians want to do all these tests before they see the patient back. So they'll say, I'll see Mr. Smith back in a year with his nuclear stress test and echo and carotid ultrasound.
All done.
And after those are done, I'll see him back and tell him everything's okay or not. And so we kind of want them to be seen first, see if they need the test or not. If they're doing well, they don't need it. But that adds to the inefficiencies in the office. So that is a challenge. Sure.
And do we find if they get all of those tests that sometimes they find something maybe that's there that they have to investigate further that creates more testing?
It's a great point, and that's the problem is every once in a very great while, absolutely you will find something, and you always hear about that. You're doing the peer-to-peer, you denied this routine test, and I had a guy once who he had to go to bypass again or something like that. So that's unlikely, and usually if you do find something, it's something small that would generally require medical treatment anyway. So the answer is yes, but you, again, what we're talking about sort of is more population health management, right?
Yeah.
It's challenging because when you look at studies that are done, they're all population based. When you talk about what we're talking about is population based. The truth of the matter is, when we see a patient, it's not a population.
Right.
It's a patient, a guy, an individual that's sitting there in front of you. And so you always wonder about, that one guy that you did, or would have missed or something like that. So that does make it a bit of a challenge. Yeah.
Have I told you that Nicolas has had 3 or 4 fetal echoes?
No.
Have I told you this?
No.
So I'm a classic case of overutilization. Yeah. So when I was pregnant, I had like 6 or 7 ultrasounds. And at the last one, they found a shadow on the heart, right? And so they're like, he needs to have a fetal echo when he's born to check that out, which I was like, it's nothing. It's an ultrasound in utero, right? So they did it. And then the heart was in transition, right? He was not even 2 days old. So like, we have to do it again. So they did it again. That issue cleared up. There was no shadow on the heart, but then there was a vein that should have closed, and the vein hadn't closed.
Yeah,
so then we had to have
PDA,
So we had to have another one at like 6 months old. Well, the vein is kind of sort of still there, so now he has to have another one at 18 months old, and if the vein doesn't close, then they may have to do like a routine thing to go in there and close it, right? But it's just interesting because it was like what they were originally monitoring for, they found something different, totally different part of the body, and now we're monitoring that for the next 2 years. To what end, I guess?
So that is a pretty classic example of some of the issues that we get into with overutilization.
Yeah.
So it's not just a cost thing. It's also a finding of things that turn out to be not important.
Yeah.
So a PDA is generally picked up on exam because there's a murmur there.
And there's no murmur. He has no murmur.
So it's probably really small. That's the other problem is when you look at the studies, all of our studies are like, when you find these things in physical exams, right? And when you get to a test that is, like echoes in 6 months old kids, the technology, the images have gotten so much better than they used to be 10 or 20 years ago. So it's almost too good. Like we can see really, really small, really insignificant stuff.
Yeah.
And so now there's a PDA, but maybe that type of PDA was seen in people, forever, and we never did anything about it because we didn't know they were there, and it doesn't cause any issue. So now you're going to end up dealing with as a thing in 6 months or 18 months. It's going to still be there, and now they're going to say, we want to do something, but there's no murmur, and the question, and he's doing fine, and so you're sort of scratching your head, going, what do we really need to do? It happened when MRI first came out in CT scanning, especially of the abdomen. So the CT scan is a great test. So normally when you take an X-ray of whatever, it's a 2-dimensional picture, right? And so you don't know, like if there's a spot that looks like it's on the heart, you don't know it could be in the heart, could be in front of the heart, could be behind the heart, right? You don't really see it. Now you can turn the patient, you can do a view from an AP view and then a lateral view, and you can get an idea. But even then, it's challenging to do. So CT scan comes out in the, I don't know, I'll date myself, I guess probably in the late 70s, I'm guessing, or maybe mid 70s, and it gives you a cross-sectional view of the body, like you cut the body in half, basically, and you're looking at it, and so you can see where it is, and you get a lot more detailed information. It's a higher resolution picture, basically. Well, that's, again, for diagnostic purposes, that's wonderful, right? You would say, what's wrong with that? Well, all of a sudden, someone's got abdominal pain, and you do a CT scan, and everything looks fine, nothing to cause the abdominal pain. However, there's this mass in the adrenal gland. And you're like, oh, geez, there's a mass. That's bad. That's, probably has nothing to do with the pain, but, a mass could be a tumor.
Yeah.
Right? So that probably needs to come out. And so there was a lot of surgeries done, and then they look at the mass under the microscope, and then you find that it's just regular hypertrophied adrenal tissue. No tumor, nothing that needed to come out.
Yeah.
So we ended up actually calling those incidentalomas. There were incidental findings that looked like masses that didn't need anything, but a lot of surgeries were done. So again, extra testing isn't necessarily a benign thing. More information is not necessarily always better.